5, 4, 3, 2, and 1. We are live now.
Good morning, everybody, and good afternoon for those of you where it's afternoon. My name is Scott D'Amour. I'm a Vice Chair of Region 16, and I'd like to welcome you to our second day of our American College of Surgeons Committee on Trauma and ATLS Region 16 conference, which for a second year in a row is virtual. Today, we'll be having the virtual education session, which I will introduce in just a second. I'd also like to thank again our hosts for this two-day meeting, the Indian Society of Trauma and Acute Care. I'm very grateful that they were able to include us in their plans for this year. It's a shame we couldn't all be there in person. I think we were looking forward to going to Rishikesh, and yet here we all are in our homes and our bedrooms and our offices doing it online. Nevertheless, thank you again to Professor Misra, Professor Gupta, and the team that they've assembled in India. They've done a wonderful job yesterday, and I'm looking forward to today as well. Our first session today is, as I said, a virtual education session. I'll be turning over the chair of today's session to our regional educator and also chair of the Senior Educators Advisory Board of the ATLS International Educators Group, Ms. Debbie Paltridge. Ms. Paltridge, welcome, and I'll hand the chair over to you for today.
Thanks very much, Scott. So I'd like to echo Scott's thanks to our Indian hosts for doing such a wonderful job of hosting the meeting, and it's my privilege to be chairing this session this morning or this afternoon, wherever everyone is. So just a little bit of housekeeping to begin with. So the next couple of hours is divided into 3 sessions. The first session will be focusing on the provider course and the experience people have had in changing their provider courses to deal with the pandemic. In the second session, we'll focus on instructor course experiences. The third session will be a brief session on quality improvement processes. And at the end, I'll hand back to Dr. D'Amours to announce the winner of the resident paper competition. So after each section of presentations, there will be a panel discussion where you will have an opportunity to ask questions. So I'd remind you to please use the question and answer function in Zoom or put your message in the chat function, and that will be being monitored, and we'll be able to ask your questions to the presenters when they've presented. So it's my great pleasure to introduce our first presenter, who is Professor Vinod Jain from India. And Professor Jain is going to talk about experiences with provider courses in COVID times. So thanks very much, Vinod.
My sharing screen option is off.
That seems to be starting to work, Vinod.
Yeah.
Yes, there it is.
Good morning to all of you. From here. Yeah. So we are presenting our experience with ATLS provider course in COVID times, especially at King George's Medical University, Uttar Pradesh, which happens to be the largest university of the Asia, having 4,500 beds. And these are the courses which you can see, which we are conducting right from the December 2019, if you take. And if you see that we put the courses on hold for 4 courses on the first wave, and we could not just do the courses after the 29th February 2019. Then, as you will notice that from 24 participants, we reduced the participants number to 16. And then, of course, again, the second wave came in, and we have to put our courses on hold. And if you will observe, then in the August course, after the second wave, you can see in the first course, that is the August course, the same district, that is from the Lucknow only, then followed by the same state because there was some problem with the interstate transfer. And then subsequently in the October 21 and the upcoming courses in November and January, we are incorporating participants from all over the country. And this is again the same story for the instructor courses. For the details will be told by Professor Atkoli. And you can see that in this also, if you will notice that when we put our courses on hold after first wave, you can see only 11 participants. That means what? One participant was less just because it was COVID positive. Why and how we tested will tell later on. And of course, the same story was true after second wave as well. Then the question comes, then why, what, and how? Why we stopped? We basically stopped to have a safe learning environment for all. We never wanted to harm anyone, or the participant, or the faculty, or the mulajis, or the office persons, so that they can be affected by the infection. And then, of course, we followed the principle of do no harm, what we keep on teaching in our ATLS. Why we resumed? Because we need to build the capacity building. We need to do the capacity building. We cannot just stay as such. And we need to refresh our teaching skills. Moreover, all the activities, why we resumed was because of passion for the ATLS under the chair of the session, as well as with the Indian team, the ATLS India chair, Professor M.C. Vishal, Professor Amit. Then how we resume, that is the question. What novel approaches, what modifications we did in our university, that is the main thing. So as soon as we stopped our first course, when the pandemic broke, we informed all the participants, we explained through phone, through email, we refunded their full administrative costs. Of course, we need to inform our university administration, as well as we informed the ATLS India chair, Professor M.C. Vishal. Then when we restarted, again, we had to take, because we are the government university, we took administrative approval in writing. And then, as you have seen, we reduced the number of participants to 16. Of course, needless to say, after meticulous sanitization, of explaining the COVID appropriate behavior through email, through phone, personally. And one thing was important, that it was mandatory for all of us, including participant faculty, that they should have the negative RT-PCR report. We never compromised on the RT-PCR. And we allowed only local participants. Suppose after that only, when we started, we allowed only local district. And then in the sanitizer kit, we also put the triple layer or N95 mask as well as sanitizer. And then sanitizers were kept at all the strategic places. One thing was we are very particular. We did not allow without COVID RT-PCR report and without mask. And even if they were having negative COVID RT-PCR report, they were having symptoms, we did not allow them. In this scenario, what happened, that one of the faculty could not join because the report came out to be positive, then we have to replace another faculty. And the same was true with the participant. As you will see in the number, you must have observed, the number became less in the courses. Then we asked one resident to be there as sort of COVID help desk. He was there with the thermal screening for the SpO2 and all the facility. Suppose if there's any problem with any of the faculty member or any of the participant, any of the office person or any of the mulajis, that should be taken well care of. But fortunately, we did not have any problem during the course. Normally, we are using towels in our washroom in India, but we did not use towels. We only use disposables. And of course, this briefing of the COVID appropriate behavior was told initially before we started the course. And in that way, we were strict because anybody, and we told them very politely, yes, if you are not following this appropriate behavior, then you may leave the course. What actions and modifications when we started after second wave? The same instructions and the measures as taken before. As I keep on saying that initially when we started after second wave, we took the participants of the same district with negative RT-PCR, but subsequently all of them were vaccinated. So we relied upon the valid vaccination certificate. That was enough for us. And again, we started with the phase managed from the same state, the Uttar Pradesh. Then from the October 21 onwards, we allowed participants from all over India with valid vaccination certificate. And now we are also having our upcoming course in November as well as January. Then during interactive discussion, what are the modifications? So after second wave, we requested our ATLS India chair, Professor MC Mishra, to be there virtually in all the sessions after second wave. So to take the course overview as guidance. So this morally boosted us, all the participants, they felt confident. And sometimes we also invited Professor Amit Gupta and Professor Subodh from the New Delhi AIMS. So that the moral of all the participants were boosted, all the you can see the workers, faculty, they were very much motivated. Then while taking the interactive discussion, apart from maintaining distance between the participant, apart from the masking, the only thing what we did is that we did not move amongst the participants. Normally in the interactive discussion, we keep on moving amongst the participants. We kept maintaining distance. And moreover, the speaker was not having mask. That I must share with you. The speaker, because with the mask, if you are speaking, then there is a problem. And moreover, the participant cannot see your face. They may be disinterested. But the distance, we just saw to it. And questioning was done from distance only. And that was the thing. And no liquid, no snacks was allowed within the hall. Normally, we are having 4 participants in one skill station in one rotation. But here, normally we teach all the 4 participants together, one faculty showing all the procedure. But here, one faculty, one participant. That means at a time, we were teaching only one participant. Of course, all the participants were standing in the room, maintaining a distance, but they were not just in the vicinity of themselves. And after the rotation was complete, we sanitized the mannequin, the equipments, and the atmosphere with the spray and some sort of skill like the log rolling or the pelvic immobilization, like the traction sprint. These are the skills where you need more than 2 or 3 participants. So that it was shown through video demonstration. And of course, the secondary survey, normally we keep moulages, but here we use full body mannequin. As you can see, the full body mannequin and 1:1 ratio, one participant, the secondary survey station is going on, and we are maintaining distance. Here you can see that while we are taking the session of the airway, you can see the distance between the participant and faculty. That was a challenge for us. That we could not maintain, I must confess that. Of course, the distance amongst the participants, as you can see in the picture, it was maintained, but the distance between faculty and the participant to whom, that is one faculty, one participant thing. When we were taking initial assessment, it was mandatory to have a proper PPE kit for the participant to wear. And of course, again, 1:1, and all the cap, gown, shoe cover, gloves, everything, whatever we used, it was biomedically disposed as per norms. And if we are using moulages, we just instructed moulages that they should not speak. Of course, they will mask. Then this is about the post-test. As you can see, again, the post-test, the number of participants is otherwise also half, so we can maintain the distance easily. What we did is that normally we keep the pencil eraser and this thing for the next course. But here we destroyed all the pencil and the eraser what we gave to the participant for the test, for the post-test, we destroyed it as per BMW guidelines. And for the new courses, we use a new set of pencil, eraser and all. And this paper also, it was destroyed. And while checking the answer sheet, the score sheet, the faculty and the coordinators, they use the gloves. Then as far as the lunch and snack time, proper spacing was done, of course. We normally do the buffet system, but here we started using packed lunches and the packed snatches and the water in the separate bottles. So all these things, and once we are used, all the things were daily disposed. We are having incinerator in our center, and we daily disposal of the biomedical waste as per the standard guidelines of the COVID, because our hospital was also a COVID hospital. So person from the BMW used to come in and take. And these are the few challenges. As I maintained you the social distancing, told you before, between instructor and the participant during hands-on training. That was a big challenge. The time management was again the problem, because after this 1:1 mentoring, then it took more time in the skill station. Then after the rotation was over, we have to sanitize the mannequin and the atmosphere. Again, it took time. And of course, the participants, they did complain about the hot food, because in our India, we normally take hot food. So that is why we keep on the buffet system. So they told that this food was not hot, and that was basically a challenge for us. And then, of course, we could not demonstrate certain skills, because we wanted to demonstrate face to face. What I feel that when you do the learning is very good, and their retention power is very good. But yes, because of the constraints, we could not show face to face like log rolling, traction split, and the pelvic immobilization. Then I must confess that in spite of continuous monitoring of the participants and the employees, few of the participants, they were not using the proper mask habits and all. So they were properly instructed. So that again was a challenge because normally 50% were there. And we are having a huge facility at our center, KGMU. So the spacing is not the problem. But yes, as a behavior, they have to follow. Then there was a difficulty. So many requests came into us that we have to maintain instructor status. So how can you maintain, because the courses were less, there was not as much as they required. The other sites were not having courses. So that was the main problem. And subsequently, the ATLS USA, what they did, they just increased the period to 1 year. That we are very much thankful to them. Then central air conditioning, suppose a few of the courses we could run in during the winter season, though the central air conditioning was banned, but when we are conducting our courses in the August, September, the atmosphere was hot and humid, and we use central air conditioning, that I must say. But overall, participants went enthusiastic, went satisfied, with positive note, and with the belief, all the participants, all the faculty, all the persons involved, they had a strong belief that we can do it. We can do it with all the COVID appropriate behavior and teamwork. Thank you. Thank you very much.
Thank you very much, Vinod. That was a fabulous presentation. I'm sure you'll have some questions in the question time. We're going to move on straight with our next presentation. I'm very pleased to introduce Commander Dr. Pali Ravi, also from India, and Dr. Ravi is going to be talking about experience with provider courses in COVID times, the experience from the Air Force Command Hospital. Thank you very much, Pali.
Thank you, ma'am, for introducing me. And I thank the organizers for giving me us the opportunity to present the experience during the COVID pandemic for the conduct of ATCL and ATCN courses. I get you greetings from the largest armed forces hospital in the southern part of the peninsular part of India, than from the beautiful city, garden city of Bengaluru. This is the rough graph of the pandemic which spread over our country, India. And the arrows are where we did the courses. We did courses before the pre-vaccinated era, and of course, after the post-vaccinated era. So we did a course around July 2020, wherein the pandemic was growing up. And then after the plateau, we had a course somewhere in October. In the post-vaccinated era, we did a course in February. We did a course somewhere in August. And we recently completed a course last week, a few days back. So I will be going and covering it in two parts: what challenges we felt and we had to for the conduct of the course during the unvaccinated phase, and the challenges we had, which was much less during the phase of vaccinated phase. Now, the schedule of the course was June 2020, but during the due to the incoming pandemic, there were a lot of restraints, and we had a lot of doubts in the mind whether we can do the course or not. But the administrators are very keen in continuing the course, because not only because of the cognitive growth it gives and the skill growth it gives to the primary physicians who are posted in border towns of our country in armed forces, but also it has some strategic value, which is beyond the scope of this talk. Now, we did certain innovations. We did some process tweaks. Simultaneously, guidelines were issued by American College of Surgeons somewhere in May 2020. And the input from various other ATLS sites like Rishikesh and ATL and the guidance of the ATLS Chair India, Prof. Mishra, we were able to successfully conduct that course, 2 courses in the pre-vaccinated era. The manuals are all sent to participants 30 days in advance, both in soft and hard copy. Due to the continuous lockdown, the postal services were hampered. So we use the service mail. We have got a service mail system through which we send manuals to them. Now, the participants were all airlifted in military aircraft from their respective stations and brought to our campus 7 days in advance. And after coming, they gave a health and travel disclosure forms. The place of course, the training wing was sanitized, was made out of bound for 7 days before the start of course for non-essential personals, and was sanitized every day, twice a day, twice a day till the course, the beginning of the course, and during the course it was sanitized thrice a day. Similarly, sanitation of mannequins were done after every day, after the beginning of the at the end of the day, and during the in between the rotation of the participants on the skill stations. Now, the occupational health department did a pre-course health assessment, RT-PCR. They did if it is required or not, and they did a pre-course sensitization to all the coordinators, the faculty, the participants, the moulajas, and they issued N95 masks, face shields, and personal sanitizers to each candidate every day, including each of the staff which was involved also. Now, Bangalore July is a wonderful weather. It's rain, so there is no requirement for air conditioning in the interactive discussions. We used mannequins for trauma victims for ATC, and however, we had used moulajas. All moulajas underwent health assessment and stayed in the same campus and same facility as we were staying. Now, we maintain adequate social distancing. For interactive discussion, we gave collar mics to each of the participants because, as Prof. Zain put out, it is a very difficult for the communication because it's a tamponadic muffled voice which comes out of the mask, and it takes a lot of time to get used to that noise. So we gave collar mics to each of the participants, 32 participants. At the end of hour, we used to have a bell system where the bell used to ring and the participants used to sanitize their hands themselves for 15 seconds. And we created a buddy pair system wherein each one was checked by his partner whether he's sanitizing proper. Apart from it, the occupational health department made surprise checks. In fact, to the extent that commandant of the hospital came 3 to 4 times to visit us to ensure that the sanitation process is on. Now, for the initial assessment, we used the full PPE to demonstrate. This was done to sensitize the participants that this is the way, maybe if the pandemic doesn't come down, this is the way we are going to provide the trauma care. And the difficulties in providing trauma care while wearing this PPE for 15 to 20 minutes, 30 minutes, 1 hour, half an hour, maybe more than an hour at times when you're providing trauma care. Now, we gave pre-packed food, tea, snacks were served at the sitting place of the candidates. So, and after having the food and the tea, they used to go and dispose at the designated place. This increased the breakfast and lunch breaks by 15 minutes. Now, we have to, you will all appreciate that we get participants who see far and few the trauma cases. They are posted at the border places, border towns, next to at various medical echelons. So they were very keen in doing all exercises, all skills to be learned hands-on. They did not, in our center, they don't prefer to have video classes. Anyway, we did all the skills hands-on were to be done, that's why. So what we did, we tweaked something more. Now what we did, we had plenty of instructors with us, in-house instructors. So we doubled up the stations, like airway stations, we make 2. So each instructor was handing up only 2 students, and he was able to give half an hour to each student. So instead of 15 minutes, which normally happens if the 4 candidates are there. And he was himself doing the timekeeping. There is no timekeepers. We were able to do this for ATCN also. However, one ATCN, we are sort of one ATCN instructor, so we were not able to do it at one of the stations. And all the candidates during the initial assessment, we had used Molages for ATLS and mannequins for ATCN. All the candidates wore PPE because we wanted them to get the feel of PPE and to perform during PPE. There were a lot of issues when they wore the PPE. First of all, wearing PPE for 1.5 hours was not an easy task. They went through it, they sweated. We gave them a change of PPE also. We taught them how to don and doff also, because they're young medical officers who come to us. And apart from it, there was some initial confusion about we were not able to provide collar mics because of the logistics issue, because the stations were due from the center point where the amplifiers were there. So, but initially there was some issue of voice communication, but later on it was sorted out. But we lost some time on conducting that thing. Now, the candidates were all followed up for 7 days. So 7 days pre-course, 3 days course, and 7 days post-course. They were in a bubble. They kept it the same place. So all of us were in 17 for almost 17 days. We were at the same place. Now, the course certificates, photography, which is such an important thing, we did a certain amount of social distancing. And you can't imagine an armed forces without handshake. So we had to circumvent something. So we started something known as elbow salutes. Now, the courses after the vaccination phase. Now, vaccination phase, we had a much better time because all healthcare workers were vaccinated in January, and armed forces took a priority by the government, was given priority by the government. So most of the armed forces people are also vaccinated. So the people who were the participants who are coming from these military stations were coming from the place where already the population was vaccinated. We did 3 courses in February, August, and recently in 2021. Now, all the standard protocols were what I had described earlier was maintained. The only thing, all health candidates are vaccinated is a big day for us. As per the advice of the Occupational Health Department, we reduced the bubble to 3 days pre-course, 3-day course, and 3-day post-course. In fact, the last course, 14th, we had only 3 days of pre-course and 3 days of course, and we left them out on the 6th day back to their bases. And for the 2 days, they were the first 2 courses on 21st and the February and August, they were bought in by the military aircrafts from the bases directly. But on the 3rd course, they traveled by the civil aircrafts. Now, this time, there were a lot of complaints of using the personal sanitizers. So we kept multiple sanitizers for the various places. And instead of an R ringly bell, we changed the system to in between because it was causing the R was coming between the interactive discussions. So after every interactive discussion, before the next instructor starts the next discussion, he advised everybody to have a sanitization, so to sanitize their hands. Now, in the post-vaccination course, food was served in buffet. We maintain adequate social distancing. As Prof. Jain put, warm food is always a big issue in our country. And all the courses, the instructors in the pre-vaccinated and vaccinated also, instructors acted as a nurse. In fact, when the instructor course came, the instructors who came from outside for our instructor course were very surprised that they have to act as a nurse also. And in the post-vaccinated course, we removed the microphones and we gave them the normal PPE. You can see they are wearing the normal PPE instead of that heavy and sweaty non-breathing PPE. And we had an instructor course back-to-back with the provider course in November itself, where we had the educator and the country chair, an ATLS chair and country director coming. Too long, the lions cannot sit in their den, they have to come out. So we had a lovely interaction during the instructor course. What I must conclude with saying, we were slow off the blocks, very slow, very nervous, very, very, very skeptical. You have to appreciate the fact that during the unvaccinated phase, they are these young military medical officers who are coming from various military stations of far across nooks and corners and different terrains of the country. If they take back the system, if they get infected and go back and give it to the troops, especially in the North Sikkim and Ladakh region, it will be a catastrophe and we will not be in a position to explain things. So we were very, very slow, very nervous, very skeptical. But as the thing improved out, we gained momentum. Great feedback from the participants we got because the participants were in a bubble for 17 days. So initially 7 days, they were a little hesitant, but as the course began, they finished the course, and after the course, they were with their instructors for 7 more days. So it was continuous trauma training. In fact, after some time, the trauma training became slightly problematic. Too many questions were being asked, which, at times you don't have answers for all the questions. And about food, well, we can't say anything about it. It's you give, it's a problem. You don't give, it's a problem. Having said that, we were unsettled by the new normal, and I hope this does not remain a new normal. It is easier to do courses in a post-vaccinated era rather than in an unvaccinated era. Thank you very much. And thank you very much for the patient hearing.
Thank you very much, Commander Ravi. That was very interesting. I'm very envious of the fact that you can have participants board in early and keep them after the course. That's very unique, isn't it? I'd like to move on to the next and final presentation in this section, and I'm pleased to introduce Dr. Siraj Haq Sheikh from Pakistan. And Dr. Sheikh will be talking about their experiences with provider courses in Pakistan. Thank you.
Thank you, Debbie. And thank you for giving me this opportunity to present some of the concepts and some of the issues that bothers my mind in this August gathering. I'm working in College of Physicians and Surgeons, Pakistan, which is the premier postgraduate medical education of the country, medical institution of the country. And I am working as Director Medical Education and also an educator of the ATLS program. Ladies and gentlemen, during the provider course, I'm really bothered about the skill teaching stations and during this COVID. CPSP actually conducted its first 10th edition ATLS provider course on 7th to 9th February 2020 under traditional format, not the hybrid format. Despite fluctuating positivity rate of COVID-19 pandemic, a number of provider courses have been conducted since then. One of the problems that is faced consistently is the application of 5-step teaching model in skill teaching stations. The presentation tries to offer a solution to the problem, and the problem, what is the problem? The problem arises from the fact that all skills included in a station cannot be covered with the new format in the allocated time, as is indicated by the instructor's feedback. Analysis of the problem revealed that there is no need to apply this format to all skills included in the manual. Instead, apply the format to only complex psychomotor skills, that is, manual skills only. Plan ahead to select few skills to be taught with 5-step model. I'll cite the example of the airway station. Basic skills included in this station are simple and do not require technical dexterity. For example, jaw thrust, insertion of nasopharyngeal airway, oropharyngeal airway, safe use of suction, 1% bag mask ventilation, and 2% bag mask ventilation. Students, how to teach them the simple skills. Students must first learn to identify simple problems of airway, which if attended immediately require simple maneuvers. Such maneuvers do not require elaborate 5-step model. They can be taught speedily as under. Instructor invites students one by one to identify possible problems in a simulated patient in manipulating a patient airway and suggest required measures to overcome them. So very easily they can do the simple skills without resorting to the 5-step model. In airway station, only orotracheal intubation in adult and child and insertion of LMA deserve to be taught with 5-step model on mannequins. This is an excellent example where instructor may divide the basic skills into 3 sets of skills. 1, the simple skills. First set, chin lift, jaw thrust, and safe use of suction. They can be taught one by one in the first set. And they are the simple skills. They do not require 5-step model. Second set is the insertion of OPA, NPA, and LMA. So this also can be taught or acquired by coaching the students one by one. The last skill, which can be simply taught, is the 1 and 2% bag mask ventilation. And all these sets or skill sets can be easily taught without using the 5-step model. Instructor silent. Now this is the modified approach which is being proposed. Instructor silently demonstrates all skills included in the first set for the whole group. Instructor calls students individually. A student reads the scenario and performs each skill included in the set. Instructor provides feedback for each skill performed. So the student performs the skill and the instructor provides the feedback. Then and there. Instructor repeat the process for next 2 skill sets, and instructor may use video for some skills of the set to save time. For example, the bag mask ventilation, 1 man or 2 men. The approach ensures adequate acquisition of skills in available time. Example 2 is the breathing station. The station involves the basic skills of assessment of breathing and interpretation of chest images, which can be dealt together to identify the problem. Instructor calls the students individually to read the scenario, assess breathing of stimulated patient, and accompanying chest images to diagnose and prioritize management option. Instructor provides feedback to each student. Remaining skills such as needle decompression, thoracostomy, and use of pediatric resuscitation tape are complex intervention and require 5-step model for effective learning. Circulation station. Select 2-3 skills for teaching through 5-step model format from the following. First 2 skills may be combined, for example, wound packing and combat application tourniquet. Then pelvic binder and application of traction splint, the last two skills may be taught on 5-step model. Some of the optional skills may be demonstrated through videos such as DPL, femoral puncture, subclavian puncture, venous puncture, pericardiocentesis. Disability station. Following skills can be taught on simulated patients in whole group without using 5-step model. Focused neurological examination and head CT scan. Assessment of cervical spine and its images. Now, this transfer communication is not a manual skill, but it is a communication skill. But I think it should be taught on simulated patient how a person can make a transfer call. Following skills need to be taught on mannequin and through 5-step model. 1, removal of a spine board, and 2nd, helmet removal. Question? Any question, please? The question will be answered in the panel discussion. Just to summarize, we have to be selective and we must select the skills that are to be conducted through manual elaboration or manual skills. And we have to see that what are the skills which can be aligned with the scenario and which can be easily taught on group basis. Thank you very much.
Thank you very much, Siraj. That was an interesting presentation. I'd now like to ask all of the presenters, so Vinod and Pali, if you could turn your cameras on, please. Sorry. I'm not sure I can be. I'm not.
I am on. I am on.
Okay. Can you hear me, Vinod?
I can hear you.
Thank you. All right. So I'd like to ask the presenters to please put their cameras on and unmute themselves. We'll have some question time now. And just to remind the audience, if you have any questions, please, for the presenters, please make sure that you put those into the chat. So I'm going to take the chair's privilege and ask a couple of questions to begin with. Vinod, I had a question for you. Your one-on-one participant teaching in the skills stations, did that impact heavily on your time allocation for the skills stations?
Yeah, it did. I mentioned it because it took a lot of time, 1:1, because we had to maintain the distance between the skill participant to have their confidence. And of course, if you are teaching 1-to-1, suppose for the airway mannequin, you are teaching the intubation, then you have to call one by one. And in that way, I will agree with Dr. Siraj that here we could not follow that typical 5-step model. We just explained all the things to them. We showed them procedure by doing and verbalizing. Then we asked the participant to do and verbalize individually, one by one. And of course, this took time, and time was the problem with us.
Okay, thank you. And I wanted to know what your thoughts were in terms of you used mannequins for the instead of moulage patients for your initial assessments. You know, moving forward in the new norm or what's going to happen, is that something that you would continue to do or recommend to continue to do, or would you move back to using moulage patients?
I think if we are not having as many mannequin as we need. In stations, normally, since we are having a batch of 24, we are the only one who have been allowed for 24 numbers. So we used to have 6 stations, and 6 mannequin we do not have. We are only having 2 full body mannequin which are dynamic. So we have to use moulages in due course of time, and they are cost effective. You cannot use mannequin in all the centers.
Yeah, so that's an equipment issue, like the amount of equipment that you have. But what about in terms of how effective you found it? Did you find the mannequins work just as well as the moulage patients?
Not exactly, I can say. We just created the moulage. What mannequins we are having? We are having mannequin which have got detachments. So what the scenario demands, that exact scenario we could not create. Just we put some sort of painting and all those these things. But yes, in the moulages, it is very easy to create the scene rather than on the mannequins. I do agree with you.
So it was a little bit easier from a
Yes.
reality perspective. Okay,
Yeah,
thank you.
I would recommend moulages.
Yeah. So Pali, that sort of leads into my question to you. I'm glad to see that you've come back. You said you used the moulage patients for the ATLS course, but for the ACN course you used mannequins. And how did you find the mannequins in those situations?
As Prof. Jain has brought out, moulages are easier. The participants also find moulages easier to practice and to perform the initial assessment, because you train the moulages to give some amount of response, like the breathing response or the verbal response. And especially the the scenarios where you've got a backstab injury when the patient falls down. I think it's a B patient or I patient. So those things have to be created. The drama part or the effect part has created. It goes well with the moulages. So we did ATCN only with. We tried actually before going into the course, the first course during the pandemic in the month of July. We did a trial run with the 2 instructors, and the instructors themselves were not very happy with having the mannequins. So we said, we'll get the moulages and keep them with us for 17 days. There is no other option. For ATCN, the ATCN instructors said they are happy with the mannequins. So we said, if you're happy with mannequin, you continue with mannequins. But post-vaccination, the 3 courses, so far we have used moulages for ATCN also.
Yeah, it's interesting because, I know in our country, we don't have the option of keeping people with us for 17 days for their course. They come in and do their course and then they leave. So, I know around the world, there's been a lot of discussion about whether we should be replacing mannequins permanently with from the moulage patients. So I'm interested in hearing your experiences with both. So thank you. I also wanted, I suppose, to ask a question regarding the impact of your, I suppose, on the cost of the course with all of the PPE and the biomedical disposal. And I'm presuming that had a significant cost implication for your courses.
Ma'am, it was not, because we are a government organization. So we were not concerned about the cost. We were more concerned about the people who are coming should go back safe. So that cost as such, there is no fees for ATLS training in Armed Forces of India. So that did not impact us. In fact, I don't know whether it is impacted, but it did not impact me at least. It may have impacted the government. There's so many PPEs were purchased. So we requested the administration to give us the PPEs, and they were more than happy of giving us the.
So Vinod, what about for you? Did that have an impact on your course costs?
So not exactly as told by Dr. Parley, that we are also a government institution and we have got a lot of buffer with us, a lot of surplus money is with us. So we can really, we did not increase our registration fee. We do charge registration fee for all the participants, but since we have got the surplus money, and we could do in that only. That was not a problem.
Yeah, that's great. That's a luxury. I know in our country that would be an issue in terms of the amount of PPE, particularly the changeover, the constant changeover, and things would impact on us. Thank you. So I might check with Scott just before I keep taking up all the floor. Are there any questions from the audience?
I haven't seen any in the Q&A box or the chat box, but I've mentioned it in there for people to ask a question. I have a question if I can ask one. Is that all right?
You can ask one. Thank you.
The question I had was for Professor Jain. Just you did mention in one of your slides that between participants, you were sanitizing the atmosphere. And I just wondered, was wondering how you were doing that. Was it a spray or was it, waiting for a cycle of air to go through by a couple of minutes, or what was it?
No, it was basically a spray what we are using in our domestic purpose. That was basically a Savlon spray what we used, and we had got plenty of the spray, and I think we felt safe in that. And that spray can be used for the clothes also. Right. And for the sanitation of the mannequin, we did wipe the mannequin.
Yeah, it sounded a lot of work for sure. And just a question, I know both courses had a plan for minimizing the risk of people being there that were potentially infectious. The military and Commander Ravi had a long period of isolation beforehand and afterwards. Others had tests. With all the courses that you ran during the different waves, did you have to take people off the course who were suspected of being infectious? And did you actually have any infections during the course or after the course that you suspected were either contracted during the course or spread during a course?
The question is to me?
To both of you. To both of you.
Okay, so as far as I am concerned, we did not just isolated the participants because we did not have that sort of facility in our institution. We only relied upon the negative RT-PCR. And as far as the follow-up is concerned, we just told all the participants, anybody who is having, because we are using the local participant to start with initially, from the same state. So we just told them if they have got any problem, they can contact the person. But luckily, we did not have any such type of response, or during the course also, we did not have any of the participants who's having symptoms. Rupali.
Yeah, thank you, Scott, for asking the question. Actually, this whole thing was dealt by the Occupational Health Department. How long they will be kept in the bubble, and who will undergo RT-PCR. In fact, in India, the first wave, anybody going for RT-PCR was socially ostracized. So we never came to know who all got RT-PCR checked, but luckily all of them were in the course. So most likely they, after coming to our place, none of them develop any signs and symptoms. Whether the pre-course RT-PCR was done, that was the at the base before they came to us. Definitely, I think they would have. I'm not privy to whether they had done it, not because we just get the candidates list. You know how military works. You have to go do a job. You don't have to, see how they are coming. So before at the military base, I think they would have undergone RT-PCR, and those who were RT-PCR negative would have been sent for the course. And once they went back from our place, I'm not privy to that information also, whether they underwent RT-PCR again or not. During the course, if they none of them developed any sign and symptoms, and in case they had developed a sign and symptoms, the call was with the Occupational Health Department whether to do RT-PCR or not. Thank you.
Thanks very much, Pali. I had a question for Siraj, if I may. Siraj, I know in our country, our instructors at times struggle with the understanding of the difference between a cognitive skill and a psychomotor skill. So, for example, reading a chest X-ray is clearly not a psychomotor skill, and the 5-step model is not required. Whereas intubation, for example, is a psychomotor skill, and you need to use the 5-step model. So I wonder whether some of what you're talking about is the challenge we all find with explaining that difference. Could you comment on that?
What is the question, Debbie?
There's a request for Dr. Siraj. Can you open his camera, please?
The camera is on. My camera is on. Debbie, I didn't follow your question.
Sorry, I'm just coughing. Scott, could you
Do you hear me?
Yes, we can hear you, Siraj, but we can't see you. So I don't know if your camera is just not working.
Okay.
So, Siraj, my question was the
Yes.
difference between a psychomotor skill and a cognitive skill.
You are off.
Just in,
Yes. Hello.
hi,
Yes,
Siraj,
did
can you hear me?
Yes, now I can hear.
Okay, so what I was asking was, what I was commenting on was the fact that our instructors often misunderstand the difference between a cognitive skill, like reading a chest X-ray, which is not manual, is not technical, and a technical skill. And as we know, the 5-step model really only applies to technical skills, psychomotor skills. So do you think some of what you were talking about in terms of that choice is a lack of understanding by the instructors as to when to apply the 5-step model?
Yes, I think you have quoted the example of reading a chest X-ray, probably. And reading a chest X-ray is a cognitive skill. It's not a manual or psychomotor skill. The very term psychomotor means there has to be some motion, whether it is the motion of the hands or the feet or any part of the body. So if there is no motion, it is not a psychomotor skill, it is a cognitive skill. And there are various types of cognitive skill. For example, here you involve the skill of recognition. Then you also involve the skill of critical thinking. These are all part of the cognitive skills. So psychomotor skills are only those which involve some motion of any body part. That means manual skills. And those manual skills, if they are simple, even then they can be done away without 5-step model. But if they are complex skills, then they have to be taught through 5-step model.
Thanks very much. Yes, I agree, Siraj. I think it's very much about understanding the application of that 5-step model. Scott, can I just check, is there any questions come through? Because I know I can't see any, but.
No, there haven't. I think there might be an issue with getting them through from the platform. And I've just asked a question about that, but I can't see any on our Zoom windows, on either the Q&A window or in the chat box.
All right, well, we might move on, and if there are questions, and Amit can let us know that we can.
Vinod.
Yeah.
I beg your...
Okay. My question is, one faculty, one student, does it not frustrate the very philosophy of the 4 students in skill teaching stations? Because there is a repetition. One of the cardinal features for practicing any skill is to repeat visually or to repeat manually. So when there are 4 students in a skill teaching station and one student is performing and the other one is critiquing, then even the critique of that student helps the other student in learning the skill.
Yeah. So your point is very taken.
Is it not depriving the students from peer teaching?
Okay. So may I answer your question, Dr. Siraj?
Yes,
Yeah.
please.
That is a very good of you that you have taken note of it. See, in the skill station, all the 4 participants, they are there maintaining distance, and whatever interaction is going on between participant and the instructor, that they keep on listening, correct? So that means that is sort of reinforcement to all the participants instead of telling them together. The only issue was that if suppose you are teaching airway, then all of 4 have to come and see, and then one by one, they have to be very close. Here, what is happening? Only one participant and one faculty is coming close. Not all the participants are coming close to each other. So that it is rather a reinforcement to all the participants. Yes, as far as the critiquing is concerned, that basically we are doing in our initial assessment station, and that critiquing part is already there, always there, because they are going in the teaching session of the initial assessment. Then of course the critiquing is there, but not in the skill station. We did not do any critiquing. We did not take any critiquing in the skill stations like airway or the log rolling or the secondary survey.
Thanks very much, Vinod. I think we had a couple of quick questions, Scott. We're just nearly running out of time. If you want to ask those ones of the panel, please.
Yeah, one of them I think has already been answered. That was a comment by Dave King, the chair of ATLS in Australia, New Zealand, just regarding the clarity to the instructors. So the instructors knew which skills had to be taught by a 5-step model and which didn't, but I think you've addressed that. The other one was from Professor Lum. Do you COVID test participants on day 1? So I think that was to all of those who were presenting their COVID-related activities.
Well, for us, the candidates, the participants who came, the providers who came, they were done most likely the COVID testing of RT-PCR were done on the basis from where they were coming. And since they were picked up by the military aircrafts and they landed up within 24 hours of being picked up, and military aircrafts are all sanitized. So we did not do any COVID testing until unless the occupational health doctor felt that it has to be done. And I'm not privy to anything whether some of them underwent a COVID test, RT-PCR test after that health and travel disclosures. After the same thing was after they went back from our place to the respective bases, they might have undergone a RT-PCR depending upon what the occupational and health therapist or the occupational health doctor at that base, military base, would have decided so.
Thanks very much. Well, we'll move on now to the next section, which we're going to focus now on the instructor course experience in COVID-19. And I have a great pleasure in introducing our next presenter, who is Dr. B.V. Adkoli, who is also from India. And it's lovely that I can see you. So I think your internet is lasting at the moment. So I'm going to hand over to you to present. Thank you very much.
Can I share my screen?
Yes, down the bottom.
Okay. Is it visible?
Yes, we can. Yes.
Am I audible?
Yes, you're audible too. You
Thank
just need to put it into slideshow.
Yeah, I think it's a slideshow.
No, it's not. It's just up the top in slideshow.
Is that the case with
Yes,
everyone?
that's perfect. That's perfect. Thank you.
Yeah, okay. First of all, greetings from India. And I feel very fortunate that I'm with the allied group of the whole region educators, and also the educators and the leaders put together in this particular seminar, a unique opportunity for me to share my experience as well as to listen to your rich experiences. First of all, I am going to cover within my time limit the strategies adopted in the delivery of instructor course. And that also, I am focusing on the interactive teaching and the micro teaching and the preparations that went on before conducting the instructor course, which is key for the survival of our instructor course. Second thing, I want to present very briefly the kind of developments which are taking place in medical education in general in India. And I'm posing a question for you to ponder. Should we need to relook at the content of the educator's course, the method of delivery, and what we can do about it? I'm just raising the questions which can be taken up later. So the strategy involved was, it is a four-pronged approach. The first is briefing and sharing, which is very, very important. My colleagues from India have already told very clearly the kind of technical precautions, the safety precautions, everything in place so that the course is going to be safe and secure. So that is the first part. The second part is wonderful. We are very happy about this Google Classroom which we started in both the courses. In fact, I would say that Google Classroom is a very effective tool for establishing rapport with the participants to prepare them for the course, and it makes the delivery so simple. I thank COVID because of COVID, this idea came to us. Otherwise, we thought that the instructor course, sending a course material earlier, and on the day of the IC, they will come and they will grasp the whole thing, which was absolutely difficult task. But now that challenge we have taken in a different way, so that course preparation is the key. I will describe the two types of Google Classroom. One was test-based, wherein we took tests. The second was gist-based. We gave a gist of all the lessons and we asked them to reflect. And the next one is breaking the monotony, educator duet. In Hindi, we call it Jugalbandi. Two people instead of one person, two people alternating the session, which worked very well. Let me describe very briefly. So in the hybrid model, extensive briefing holds the key. Detailed instructions were given about the micro scenario based teaching session. And when we gave the what you call instructions, and we opened the Google group, the participants posted a lot of queries in fact, because they were concerned how to do micro teaching, how to prepare, and beautifully they were pulled together, and the course director gave a lucid explanation of the process, how it is going to happen, and what is their role as instructors. So all the queries were answered. So the preparation part of the instructor course was heavily done satisfactorily because of this Google Classroom. And in a test-based approach, I am not going to give the details of the test. It was a simple test because that test, assessment drives motivation. That is the mantra. So if you can give a very brief test just before the workshop, instructor course, that is going to motivate them. They will, just warm up. So this was a very simple test designed by Dr. Jayaprakash Rajan, who is not there today with us, and myself together. And this includes true, false types, MCQ type, and short answer type, because these are the very simple formats in which our Indian medical educationists are familiar. So just I have given an example, true, false type. In the interactive discussions, the facilitator should provide solution to the problem. The false thing. Convergent questions usually aim at lower levels of cognition. It's the true. Then there is a MCQ type. I'm not going to do this because you are all educators. You know the content. You are the master of it. So there is no need for me to tell you about these questions. And the short answer questions: which domain of learning is inadequately addressed and why? Let us be clear that we may not expect very rich and accurate, authentic answers from the participants, but it will make them think in that direction. So that is the beauty of this testing and how it worked well. In the gist-based approach, what we did was we aligned with the sessions of the educator, and every day we flashed a session. Adult learning principles. Okay. About that, they are supposed to reflect and send their comments. For example, this one, reflect on your routine teaching or presentations made during conference, etc. What factors made you excel or feel that you could have done better? Relate them with the adult learning series. The participants, we say that adult learning, adults are coming with a lot of experiences. They have done a lot of teaching. They have attended conferences. So our assignment just makes them think, reflect, and try to relate with what we are going to deliver during the instructor course. And we also share some YouTube link. For example, we picked up a YouTube link by Bill Gates. He's talking about feedback in China. So this is a very thought-provoking video, and it was shared with them. Besides, I also shared one of my blog posts. I write blog posts in Times of India, one of the very leading newspapers, and this was on feedback culture. So I just give the blog. It's very simple, 5 minutes reading, and they can think about it and they can send their reactions. So in a summary, what I want to tell is that the testing approach combined with the reflection approach, this approach is going to give a well-rounded experience for the participants. They act as appetizers and they motivate them to come with the workshop with full preparation. This is the workshop which we held in Jodhpur, 27 and 28 February 21. You can see Professor Mishra here, the ATLS India chair, and of course Dr. Jayaprakash Rajan here, and Dr. Sumit Banerjee, who is the director, course director of this particular site, and Dr. Ajay Sharma, who was a very motivated person from UK, braving his timing differences. He joined all through to give very good feedback for the micro teaching and other sessions. And tell you, micro teaching, I had a discussion with the course director. How was your experience about micro teaching? He told that, sir, we did not miss much educators because they were there on the site. They observed the lessons carefully and they gave very rich feedback. And this is what happens, because I myself have experienced several times. If I have to give my comments as educator last, nothing will be left to me. All the colleagues will tell, they will pick up everything plus and the minus points. So that's the beauty of this, the power of micro teaching, which did not suffer anyway. Coming to the educator duet. This is a point which I am making politely with conviction. Believe me, the ATLS instructor course as it is designed now contains a package and overdose of educator sessions. At least first day it is about 6 or 7. Next day also there are 2 or 3 which are important. And this is tiring for the educator. So the strength of having 2 educators was that we could alternate the sessions. So the educator also got rest, and at the same time change of voice, it breaks the monotony and it reduces educators' fatigue. So this is the strength of having 2 educators instead of 1. Coming to the weakness, of course, in virtual environment, there is no issue on part of the travel time and the cost. It's a time saver. But you can question, is it a waste of human resource? Because sometimes, the both educators should work in unison. So that issue has to be seen, how you can work out the what you call understanding in between the 2 educators, complementing each other. But I believe that ATLS is a culture. It is a culture of teamwork. So that's why 2 educators will definitely work. Coming to the present Indian scenario, there is a lot of wave of changes in medical education. Our undergraduate and postgraduate medical education is moving to competency-based medical education. This is, in fact, the trend world over. CBME is the buzzword. Now, still we have Bloom's taxonomy in the ATLS. So please let us rethink whether Bloom's taxonomy is it really required, or we should switch over to some other model like Miller's pyramid. Miller's pyramid is another very, very popular model. But I see a lot of strength in Dreyfus model. The Dreyfus model, which I have shown here, it is a movement, and already ATLS is built on this particular philosophy. If you recall, there is a slide showing from, what you call incompetent to competent. Okay, from unconsciousness to consciousness. So the 4 stages will be, there is a slide, you remember. People will move from unconscious incompetence, then next conscious incompetence, then conscious competence, then unconscious competence. So this is a beautiful slide which makes an impact and shows the pathway for developing expertise. What we can expect in an instruction code, again, it is tell in several slides that we can bring up to the level maybe 3 or 4. You can't expect level 5 because that comes with practice. So that brings us to the next changes which are required. One is the concept of community of practice. Many participants tell me, sir, it is instructor course is wonderful, but how we can catch up with the changing trend, how we can share the experiences. So there is a need for a network, a portal which answers all the questions, queries, and gives an opportunity for free exchange of expertise, practices, and the solutions. The second one, I am moved by the self-determination theory of motivation, Ryan and Deci. Of course, we talk about motivation, there is a slide about it, but this particular input, I'm very much impressed because it talks about motivation linked with 3 factors. One is the degree of choice, freedom given to the learner. The second is the support given to the learner through mentoring and feedback. And the third aspect is, the trust, freedom, motivation, and the competence, pursued competence. Pursued competence is perhaps more than the competence. If you can place together these 3 things, ATL is going to be a wonderful journey. So thank you very much for your time, and let us work together. And I hope Debbie will take my things forward, and we can always think about it, debate, and discuss. Thank you, Debbie. Thank you, everyone.
Thank you very much,
Can I
Dr.
talk, sir?
Coley. Yes,
Can I talk?
please. Yes, thank you. So thank you very much. I have a couple of questions for you. I just wanted to also, before we open up for questions with the audience, also to let everyone know that we have actually had our first successful induction of an educator in Region 16 remotely, which we've never done before. And obviously that was forced on us by the COVID situation. So Hong Kong needed a new educator, and I have very special thanks to the Singaporeans who allowed that educator to watch their first instructor course remotely into Singapore, and early next year or mid next year, when that educator does their first instructor course, they're going to be watched remotely by the Singapore educator. So I think that's a fantastic example of collaboration within our region, and something that in the future, without taking COVID into consideration, that we could actually look at doing, to have that cross-fertilisation between educators. So Dr. Coley, I just I wanted to clarify one thing with you before I ask to see if there's any other questions from the audience. But your use of Google Classrooms, I'm very interested in. Did you use that during your instructor course or before the instructor course?
Before, at least 1 week before the instructor course.
So
Because
a week before.
Yeah, at least 1 week before, and we started even first, for example, introduction. Okay, usually introduction we do it on the first day, first session, but here this is an opportunity for getting they will post their picture, and we also supported by WhatsApp group. Google Classroom is definitely more powerful to do so many functions, but WhatsApp people find it very user friendly. Whenever they are there, they can just respond, they can ask a question. So I think technology convergence is required nowadays because people use different technologies. So 1 week before is ideal.
Yeah, well, I have to say that the Senior Educators Advisory Board are currently working on the 11th edition instructor course, and we're rewriting the whole manual. So you will be pleased to know that all of the references will be being updated, and I'm happy to take your suggestions forward to them. But one of the things that we are doing is aligning the 11th edition instructor course with the 10th edition provider course. So there will no longer be interactive lectures, there will be interactive discussions, and the participants will be expected to have read the manual before they turn up to the course, And I think your suggestion of using some technology pre-course like Google Classrooms is fantastic. So I will, definitely share that with the other educators on the educator board. So my other question was, the pictures that you showed looked like your instructors were remote when you were doing the instructor course. Is that right? Or were those pictures just of your Google Classroom? I was a little bit confused.
About the educators' lessons, you mean?
Yeah, so
when the sessions, we were taking sessions, they were in a classroom, okay? They were in a classroom, they were all together. It's not a question of using individual systems.
So the people that were remote, were they doing a session or what was their role?
They were all sitting there and we could present it and we could ask questions. Only problem was the mic was passed on to individually. Otherwise, we can't listen to their thing.
Yeah.
Ideally, it should be, when we say group learning, it is each person holding a system. But here, the course is on. The course is happening.
Yes.
Okay. So that is how this is of hassle, but it will work out. It will work out.
Thank you. Scott, I'll just check, are there any questions from the audience, please, for Dr. Akoli?
I do not see any in the chat box. They do have to copy them across from the platform, but I have reminded them and I don't see anything there at the moment. Oh.
Yes, Scott, just an announcement for all those in the hall. If you see the hall, there is a tab or a link on the right side which says ask a question. Anybody who's in the hall on the front end in the conference side, kindly tap that. You will have a chat box. You can type your questions there and they would come to us. So kindly be interactive, kindly post your questions and ask the question box, and that will automatically come to us through chat and your questions can be answered by the panelists. Thank you.
Thank you, Amit, for giving a very important input. One thing I wanted to tell is that there is a need for a network of resources, expertise put together to handhold the instructor for a long time. Because we always say that it is not just one-time job. It is a journey. And the journey we have to be together. So we need to walk with the learner, not only during IT, we should walk for a lifetime.
Absolutely.
We stand behind it. Yeah.
Yeah, so the follow-up with the instructors when they actually go out, that's right. It's very, very important. Thank you so much, Dr. Akoli. I'm going to close that particular session and we're just going to move on briefly now to look at quality improvement processes within ATLS. So I'm going to share my screen and do a brief presentation. This presentation was given to the ALTC the recent trauma conference, and I was asked to share this with the region as well. So I'm just going to talk briefly on the process improvement approach and the impact of our process improvement approach on our Australasian program. And I'm going to talk about the quality improvement processes that we have in place from a course conduct perspective, a provider course conduct, from a faculty communication perspective, faculty development, both ongoing and if we have new additions, our instructor recruitment process, and our instructor course assessment. So the objectives of this session, hopefully by the end of this presentation, you'll have identified the process improvement activities that are conducted in our program and reflected on how you could include process improvements in your program. So we have been very committed to ongoing quality improvement since the inception of ATLS in our country. And the reason that we are very passionate about this is that we want to make sure that we're consistently delivering high quality ATLS programs. We want to maximise the learning of both knowledge, skills and attitudes in our ATLS courses, but more importantly, we want to actually facilitate that transfer of learning from the ATLS course out into practice so that it does make a difference to our trauma patients. We want to maintain and foster our current current faculty, and we want to recruit and train new faculty to the expected standards. So in terms of our course conduct, one of the big things we've done is to assign mentors pre-course. So the faculty are allocated individual participants as their mentees, and they contact those participants prior to the commencement of the course. And they set out the expectations of the course, the need to read the manual, how the course is going to be run, and the interactive nature of that. And we've found that very successful in firstly welcoming them, the individual participants into the course, but also the degree of preparation that we get prior to our courses. Our faculty, just from a context perspective, are in attendance for the entire course, not just for individual sessions. And as much as possible, we try and have pre-course faculty meetings the night before the course commences so that the faculty are all on board. And that is where we remind them about things like the 5-step model. So another area that we work very hard on in terms of quality improvement is our faculty communication. So we think communication is very important to maintain our faculty engagement. And our routine communication is we have a quarterly faculty newsletter, which includes both a a message from the chair. It has an educator article, so I might write an article on giving feedback or the 5-step model or something like that. It has course updates and, of course, any policy changes that come through from the American College. We also have a process of reviewing all of our director reports, so that the director's reports are reviewed by the committee chair, the senior educator and the national coordinator. And we've just recently implemented an annual letter to all directors, and we are giving them feedback on what action's been taken as a result of their director's report, so the changes that we've made, and also if no change is made, the rationale of why no change is made. And again, this is an attempt to keep our directors engaged and recognising that those directors' reports are taken very seriously. The other thing that we do in terms of our quality improvement processes within our, I've gone the wrong way, is faculty development. So we have an ongoing process of faculty development where we have implemented a peer review process. So basically at the pre-course faculty meeting, the director actually allocates each of the faculty to one another, so they're in pairs, and we've developed a feedback form for them to use that's based on what we teach in the instructor course. And the faculty then watch their fellow faculty teach. They fill out that form and they sit down with them after their session while someone else is teaching, and they give them feedback on their teaching. And that form is then given to the person who was receiving the feedback, and it's kept just for their own personal reflection afterwards. So it's not, we don't collect the forms, it's purely a faculty development process for them. In terms of our new additions, when we have new additions, we obviously have written communication out to our faculty, but we also have made a very big effort to get out to our faculty and have face-to-face meetings and workshops that are actually attended by the chair of our ATLS committee, our committee members and senior educator and the national coordinator. And these workshops are to help it's a chance to upskill and also talk about the new addition. The other thing that we've done is in our instructor course assessment is that obviously we still follow the ATLS requirements in terms of what assessment is done, but we've actually added a form that goes with each of our instructor candidates to their first course and is given to the director. So we actually let the director know what they performed well on the instructor course and any specific areas that they need to work on. And we also have a process where we put some instructor candidates on specific courses with specific directors if we need to have some tailored mentorship for those instructor candidates. So again, trying to tailor the support that's given to the new instructors to their particular areas that they need to work on. In terms of our instructor recruitment, we still have to have them identified as potential instructors, but we have a very rigorous application process to become an ATLS instructor. We ask them to fill out and complete an application form that includes what makes a good instructor, why they want to be an instructor, to provide details of an education session that they have conducted themselves. They have to explain how it was delivered, what worked well, what things they would change next time. They have to give an update on their current trauma experience, curriculum vitae, and references. And these applications are reviewed by the instructor course director and the senior educator to really carefully vet who gets onto our instructor courses. So that's part of our quality improvement processes, is to make sure that we are actually getting the right instructors for ATLS. So I'm happy to answer any questions, but just the key points is that I think process improvements are a very important part of implementing ATLS. I think there are local processes that we can implement, and I've shared with you some of the local improvement processes that we have put in place. But I think it's also really important that we regionally share our initiatives with each other so that we can learn from each other. So I'd be very interested to hear other people's process improvements that they have implemented. Thank you. I'll stop sharing now.
Thanks,
So,
Debbie. I
yeah,
just had a question. Hi, yes, Debbie, I was very interested in what you said in the last slide, especially the process of selecting the instructor potential. And it's very interesting to know that you have a written format for that, and people have to apply in order to get the instructor potential and in order to enter the instructor course. What we do normally in India is that every provider course, the faculty is there and they would identify the providers as per their performance and their communication skills about whether they are having instructor potential or not. But what you just now said was adding a second layer of, say, quality control. So is it that you take some time to declare somebody an IP, and it's not at the end of the course, you would hand over the IP certificates to them? So it would take some time. So I just wanted to know the actual procedure. So because we liked it,
yeah.
I mean, I personally would like such a second layer of
so we don't
quality coming between.
Yeah. So we don't let people know at the end of their course that they've been identified as a potential instructor. So the course finishes and there's a post-course faculty meeting. The faculty at the post-course faculty meeting go through all of the participants and identify who is a potential instructor. We have a very mixed population, Amit. A lot of them are very, very junior. So for some of our potential instructors that are identified, they're too junior to come onto an instructor course straight away, because we require them to have about 4 or 5 years experience before they become an instructor. So they go on what's called a waiting list. And then when they get to that level in their training, we don't lose them. We don't want to lose them. And we will contact them and we will say, would you like to put in an application to be a potential instructor? And at that point in time, they then go through that next step and they put their application in. I think, you know, one of the things that we have heard quite a lot from our faculty is that there's very limited teaching by the participants in a provider course. They're the learner and they're actually participating. So we ask them to look for qualities that they think would make a good instructor, but it's sometimes difficult for them. So it's just we've found that it's important to actually get to find out a little bit more about these people and their interest in teaching and their experience in teaching before we put them forward.
No, I think it's an excellent thing. I would like to have the views of the National Coordinator of India, Dr. Subodh Kumar, on this particular structure of selecting the IP candidates, because they seem to be a very, very nice quality control in terms of, because we have faced that many times, these providers at a very junior level also, they do come over and at times it becomes difficult for us to say no once we have already identified them as instructor potential. Therefore, I would like. Yeah.
Hi, Debbie. It was
Hi.
a nice presentation. And
you.
I do agree with Amit and you that there should be some kind of check if somebody is identified as a instructor potential, so he will not be considered for the instructor course automatically. But having said this, it is also important to understand that the whole process should be very democratic. So it should not be at the mercy of somebody is not liking a particular person, so and his application will be rejected. So there should be an objective criteria. I would suggest that yes, if somebody has been identified as a instructor potential in a provided course by 5 or 6 instructors in a provided course and the course director at a X site, so it will be rated as, say, out of 100, you will be marked. So for example, I'm just giving you an example. So you give a 80% marks to the criteria that he has been identified as the instructor potential, number one. So in my experience of last 12 years of running the ATLS India program, generally in a course of 16 participants, not more than on an average 2-3 students are identified as instructor potential, number one. So there should be some objective criteria. I do agree there should be some check and balances. So like 80% or 70% if you are identified as IP, number 10 marks if you are working in you are engaged in a trauma services or if you are providing a trauma care, 5 marks for other things, your CV, your liking like this. So some kind of objective assessment should be there so that it should be more democratic rather than somebody is on the whims and fancies of a course director or ATLS chair.
Yeah, so just to clarify, if it's, for example, Scott and I are the two people reviewing the assessments, the application forms of the potential so the potential instructors are identified by the faculty at the faculty meeting, and they agree who they're putting forward, and that gets put through to the office. They then get asked to apply if they are interested, because not everyone who's identified as a potential instructor wants to be an ATLS instructor. So we ask them to apply, and then we review those applications very objectively, and we are totally blind to these people. We've never met them before. We haven't taught them before. So it's really on what the information that they provide to us. So we ask them, what do you think makes a good ATLS instructor? You know, why do you want to be an ATLS instructor? So there's quite a lot of rich information that comes from those, and then we weigh up those answers, and that's how we make the decision. Are there any questions? Oh, sorry.
Can I make a point? First of all, very pertinent question raised by Professor Subodh about the fairness and the objectivity in the selection process. I perfectly agree with the Australasian model given by Debbie. In fact, I would like to give a small acronym for your model. 3 P's. The first P is the performance of the candidate in the field. The second P is the passion. And how to measure passion? You have to think about it. There will be out of the box solutions for that. The third P is the peer review. And you have right now suggested that there is a strong element of peer review, so that it is not biased. So if 3 P's combined together, perhaps we will come out with a very robust model of identification criteria. And that is what, we say multiple source field, MSF, or 360 degree. That is the current trend now. In assessment, we say the only authentic assessment is 360 degree. You multiple examiners, multiple observers, multiple occasions, and multiple settings. So when you combine together, you will get a robust assessment. Thanks a lot.
Thank you very much, Dr. Akali. Scott, I think we're nearly going to run out of time here. Are there any questions from the audience?
There are none in the chat box and none in the Q&A room. So I don't think there are. No.
All right. Well, I'd like to conclude this part of the education session and thank all of the 4 presenters for some excellent presentations and some thought-provoking things. So Professor Vinod Jain from India, Commander Dr. Pali Ravi, Dr. Siraj Sheikh from Pakistan, and Dr. B.V. Adkoli from India. And I'll now hand over to Scott to share the results of the resident paper competition. Thanks very much, Scott.
Thank you very much, Deb. Thank you for chairing that session. I really enjoyed it. Thank you to all the presenters that you had as well. I think there was a lot to learn there, not only just about managing things in unfrequent and uncommon times with COVID, but some good learning points when it comes to instructor courses, and selection of candidates even as well. So thank you for chairing that session. I very much enjoyed it. We are coming to the end of our Region 16 virtual conference for a second year. Before everybody goes, I would like to make a couple of presentations. Hopefully, I don't know if we'll be able to get photos on screen, Emmett, with the big audience, or if I could just get a photo with the resident paper competition winner and runner-up. And I'm not sure if we've got all of our resident paper competition participants here in the audience and whether we can get them on screen as well. Are you there, Emmett?
Oh, yeah, we'll try to get them. There are a few in the attendees, so I'm just upgrading them.
Okay. Be nice to be able to do that. In the meantime, I'll do some of the thanks that are required for all of the work that's been done to make this virtual Congress a success for a second year in a row. And I think the team that really deserves the biggest thanks are obviously our hosts, the Indian Society of Trauma and Acute Care, for hosting our ATLS and American College of Surgeons Committee on Trauma Region 16 virtual meeting, again for a second year. So thank you very much to our hosts, and especially Professors Misra, Gupta, Kumar, and I hate to miss anybody else, I hope I haven't, but certainly the technical team in the background as well, who've done a wonderful job of coordinating the resident paper competition, getting all of those submissions, being able to get all of us online live yesterday when we did the discussants with our international group of experts, and getting our judging panel online as well. So thank you to that group. We would not have had a successful Congress or a paper competition without your expertise. I know Gilberto wished he could be here. He's at a university function and conferment that he had to be at today, so he sends his apologies. But I know he wishes he could be here as well. But thank you to Gilly for all of his hard work in chairing the region and the business meeting that we had yesterday. I'd also have to say thanks, of course, to Professor Eileen Bulger, chair of the American College of Surgeons Committee on Trauma, who attended yesterday and spoke to us live, as well as Dr. Sharon Henry, who presented yesterday virtually. And it was also good to meet our incoming chair of the Committee on Trauma, who will be taking up the seat at the ATLS Global Symposium in March in Seattle. So thank you to all of those. I also have to say thanks to Deb Paltridge for her expertise and her help on this program. She helped me immensely yesterday with coordinating questions, but also with running the session, the virtual education session today, I think, which was very helpful and very informative for us that were here as well. Our presenters, of course, have done a huge job, not just our resident paper competition presenters, but all of the presenters who presented today and those who spoke yesterday as well. So thank you to everybody. Last but not least, Mrs. Dunstall, Leslie Dunstall, who has been the glue that holds this region together for a very long time. And she has been threatening to retire since forever, and I think is going to make good on her promise. But Leslie, we are very much going to miss your participation, your humor, and the hard work that you've done really with this region since it was conceived pretty much, but also in its infancy and its growth. It would not have happened without your hard work on that, so thank you. Have we got everybody online, Emmett, that we need to?
Yes. Yes, I think everybody has been promoted to the panelists. I think they have to open their cameras in order to be seen.
All right, where's all our presenters? I can see Randall Dialwas. I can see, who else can I see? Jason Hong.
Yeah, could you?
I can see
Yeah.
Guzhen Kwan.
Yeah.
I can see Yun Lin. I can see Takio. That is a number of them, probably not everybody, but quite a few.
Yes, so I would request the other participants or presenters who were there in the resident paper competition to kindly switch on their cameras.
Oh, there's Dr. Chakraborty as well. I think we've got, let's see, 1, 2, 3, 4, at least 5, 6 maybe.
Dr. Takio.
Which is not bad. I know it's a day later, and with all the time zones, I'm pleased. So just as mentioned yesterday, when it came to the residence paper competition, we had a wonderful group of presenters who have already won their own in their own competitions within their own countries to get to this point. So congratulations on that. I think you've all done very well and represented your own ATLS programs in your own countries incredibly well. And for that, I'm grateful, and you should be very proud of the work that you've done. I know the amount of work that goes into research, clinical research or otherwise, and to present it all in a few minutes is just a brief look at the vast amount of work that goes into something such as you've done. So I would certainly encourage all of you to continue with that work, and if you can, submit your work for peer review to a journal of your choice, because I think that's a great way of both promoting the work you've done, but also making it more visible for everybody else in the world that has an interest in the area that you've been researching. So very well done to all of you for your hard work. We, of course, had a difficult job. Our judges had a difficult job of selecting a winner and a runner-up. The runner-up is really a person who is mentioned. They don't get an opportunity to present at the international meeting unless for some reason the winner is unable to attend in person or virtually. But nevertheless, the runner-up has clearly done an excellent job as well. And I have an envelope to present, which of course we can't see because of the virtual background. That didn't work very well. I have an envelope with a certificate in it. We will send a certificate to the runner-up and to the winner so that you can post that on your wall and display it proudly as the runner-up to the Region 16 competition, resident paper competition for 2021. And our runner-up this year, as selected by the judging panel. Don't get a drum roll or anything, no? Okay. Our runner-up winner this year is Dr. Andrea Lee from Hong Kong with the abstract entitled "The Impact of Trauma Resuscitation Time on Patient Outcome in a Tertiary Trauma Center." So congratulations, Dr. Lee. I don't know if she is online today. Like, quiet, silent clapping. There we go. Well done, Dr. Lee. Are you there? Don't see her, so we'll have to pass on. That's all right. We'll have to pass on that message to her via email. And the winner for Region 16 this year, and who will be given the opportunity to be funded, hopefully, to attend in person the ATLS Global Symposium and the Committee on the American College of Surgeons Committee on Trauma Resident Paper Competition, amongst all 17 winners from around the world, all the different regions from around the world and North America. In Seattle. Hopefully you'll be able to get there, and if not, at least be able to present virtually, depending on what's happening with our pandemic situation. But congratulations to this year's winner. That would be Dr. Gu Zhen Quang from Malaysia, with the abstract entitled Reduction of the Duration of Mechanical Ventilation Using the Trachea Score to Guide Early Tracheostomy in Neurological Cases. Congratulations, Dr. Gu. Are you there? Yes, you are. There you are. And I have a virtual winner envelope to present to you, which I can't present to you, but congratulations.
Thank you.
Now, I don't think there's anything else that I need to present today, and I'll just double check my list of people to thank. I think I have covered just about everybody. If there's anybody I haven't forgot, or anybody that I have forgotten to thank, I apologize. But again, thank you especially to our Indian Society of Trauma and Acute Care hosts, Professor Misra, Gupta, Kumar, and the technical team. Again, you've done a wonderful job of pulling this complicated venture together. And I think everybody that's been here has very much enjoyed it, so thank you. Perhaps I'll leave the last word to
Thank you, Scott.
Professor
So Scott,
Gupta and Professor Misra.
yeah, Scott, just a small suggestion. Can we request the winner to share just for a minute? He can speak. Just a suggestion. The winner, if you can allow the winner to speak for a minute.
Sure, I put him on the spot. I don't mind. Dr. Gu, you're on the spot. What would you like to say?
Thank you, Scott. I'm thrilled. I'm very happy that given this opportunity to present my work. This is actually a part of a requirement for my completion of my general surgery training. It's a research project that I do in concurrent with my training. It's a requirement for me to complete my training, and I'm happy, and I would like to share this prize with people who have supported me along the way, namely Professor Lam Siu Kiong from Malaysia, my thesis supervisor, Associate Professor Kalai, my wife and my daughter, and thank you to everyone who has supported me along the way. Thank you. Back to you, Scott.
Congratulations, wonderful.
Very, very well done, and we wish you well presenting on behalf of the region. There'll be many of us, or hopefully a few of us at least there, but for those that won't be able to make it there, there'll be many online who will be cheering you on. So well done, and I hope you represent the region well. Any final comments, Professors Gupta, Misra, anyone else?
Yes, Scott.
I think I would ask our host, Professor Misra, to give the closing remarks. Professor Misra has been a guiding force between not only the ISTAC, but also the ATLS India, and he is the ATLS India's chair. I request Professor Misra to give his closing remarks.
Thank you, Scott. Thank you, Amit. Thank you, Dr. Subodh, Dr. Sushma, all the organizing team, faculty of Trauma Center, all the participants, all the presenters. And we look forward to host you on 11th and 12th November next year. God willing, or prevailing all the conditions of pandemic resolving much before that. So we hope to host Scott as a region chief we would see you next year. You will take over as region chief. So congratulations on that in advance. And we would look forward to region meeting in physical participation from the region members. So thank you so much for this wonderful meeting, which you anchored, Scott, throughout. And we look forward for that. And I'm sure what was discussed yesterday about the Leslie being basically, since she has been taking care so well, that also is a challenge for you, that whom you entrust this responsibility, and also you would have a deputy, your deputy, who can also help you in this endeavor. So we look forward to maybe interact in between, and 11th and 12th November 2022, we hope to see everyone.
Sounds wonderful. Thank you again, Professor Misra, for all of your work. We look forward. I don't know if we've selected the city for next year or where the meeting will be. I don't know if you know that as yet.
We will discuss amongst ourselves. Might be New Delhi, might be some other city, but we'll let you know in due course. We'll discuss amongst ourselves and then keep you updated on that.
All right, that sounds wonderful. Again, thank you for your hard work, and best of luck with the remainder of your Congress. And thank you for allowing us as Region 16 to take part in it and to host us again. So again, thank you, everybody. Enjoy the rest of your weekend.
Just a word to all. Just a word to all the participants who are here and also in the hall B.
You have a link. This is a complimentary link. If you want, you can see the program in hall A, and you can continue to be with us in the conference till tomorrow afternoon. Thank you so much.
Bye, everybody.
Bye.
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 Look forward to seeing you soon.
Yes.
Bye and thank you.
लाइव स्ट्रीम बंद कर